The next one is Dr. Tausi Maftaha. Dr. Tausi Maftaha is a specialist in molecular imaging and technologies, which is nuclear medicine imaging. She's the only female in nuclear medicine clinical practice in the country. She plays a significant role and serves as the IEAA country coordinator with roles of establishing, expanding, and fostering sustainability of nuclear medicine services in Africa. So she will be with us on the panel. Then we have Dr. Sikuzani Muya. She's a consultant clinical and radiology oncologist, a lecturer and a researcher at Ocean Road Cancer Institute and Muhimbili University of Health and Allied Sciences. I would also like to invite Dr. Serafini Mroso. Dr. Serafini Mroso. He's a medical specialist at Muhimbili National Hospital, specializing in gastroenterology and hepatology. He has 14 years of experience in clinical practice. He's now doing his Master of Science in Medical Gastroenterology at MUHAS. Then we have Dr. Anton Okanit. Dr. Anton Okanit, from our colleague from Uganda. He's an internal medicine physician at Kirundu National Hospital in Uganda. He's specializing in gastroenterology, and he has a postgraduate diploma in gastroenterology at the University of South Wales in the UK, and so that has solidified his commitment in gastroenterology and digestive health. So those are our panelists for today, and so I'd like to start with when you have a president, you start with the president, okay? So Dr. Eduardo Komba, would like you to take us through on what you think are the policy implications of gastroenterology and digestive diseases in East Africa.
Thank you very much for this first kind introduction and giving me the first chance to speak before all of the other speakers. That will give me an opportunity to say quite a lot without repeating somebody's messages. Yes, as we said earlier, gastrointestinal disorders are quite prevalent. There are so many, and most of them would actually impair the quality of life of those who have them, and definitely this will have some cost implication. So that is the economic burden to the patients. Now, among the policymakers, I think there are many issues that they should look at, and I will discuss maybe 4 of them. One is in policy making, we should look at the public health and prevention issues. By this, I mean one of the things that we can do is first to promote health eating or health habits. For example, there are conditions that are caused by a person's decision by deliberately taking something into excess. For example, liver cirrhosis. Many people would suffer from liver cirrhosis by excessive consumption of alcohol. So in public health teaching, we should advise people on the negative effects of alcohol and what would be the safe limits of taking alcohol. We know they cannot stop, but they can take safe amounts. But at the same time, there is one crucial issue in prevention and public health, that is screening and early detection of diseases. I think until now in Tanzania, I don't think if we have a very good screening program for any disease. Maybe recently people are advocating screening of maybe cervical cancer among women, screening for hepatitis B infection, but there is no a concrete running program on screening issues regarding diseases including cancers. So one of the areas that I think we should focus on is on screening, and by screening we can detect early diseases which are potentially curable, particularly the cancers. But there are other things which are easy to do. For example, promoting hygiene, okay, and food safety. H. pylori is quite an important cause of gastric cancer. And the acquisition of H. pylori is through eating contaminated food, transmission from human feces to the next person. You get H. pylori and you end up getting cancer at one point in time. Recently, my postgraduate student has done a research on gastric cancer, and the majority of patients who have gastric cancer have H. pylori infection, actually underscoring the effect of H. pylori on cancer formation. So simple hygiene and eating habits could prevent such cancers. So that is on the side of public health. But then coming to the government itself, there we need some issues to be settled. One of the major issues in gastroenterology is the cost of services. You go to any hospital, ask for the price of doing HAPA endoscopy, OGD. If you get a low price, 250,000 T shillings, 400,000 2 shillings, Tanzanian shillings, it's very expensive. So now how can the government make equitable access to health services? How many gastroenterologists do we have in Tanzania, and what is the cost to see them? You go to many hospitals, you want to see a gastroenterologist or super specialist, it's not less than 30 to 50,000 T shillings. So how many Tanzanians can afford? So now this is on the side of the government to make sure that health care is accessible to all Tanzanians. The other thing that I think I should discuss on the policy implications is about the societal impact of these diseases. One, as I have said, economic cost. It will really enormously increase the cost of a person who is actually suffering from a disease that is related to the GI. I was just chatting with some doctors at Ocean Road, and one of the patients needed this, what we call targeted therapy, bevacizumab. The cost of it, one injection, is 6 million T shillings, and the patient would need 6 injections. That is 30M. In this room, who can afford 30M for one injection? Leave alone other treatments that are given in combination. So you can imagine the cost burden that can actually be faced by this patient. So that is another area in policy making. How can we actually improve the cost of treating patients? But apart from that, there are issues related to quality of life and psychosocial well-being. All diseases would actually, at the end of the day, impair these aspects. So how are we prepared as a nation, for example, in handling such issues, the psychosocial issues? The quality of life is low. How can we bring this patient back to the normal state? But the other thing in policy making would be now, this is quite often forgotten, the issues of research and innovation. I belong to the academic institution as a lecturer at MUHAS. Research, of course, has been one of the major issues that we should do. It's a requirement, of course, for promotion. It's a requirement among our students for completing their studies, med students, but that is not the most important thing. The most important thing is to do research on various GI conditions, get evidence-based information on the best care that can be given, and then translate this information into practice so that doctors can apply. And some of this research can actually invent something which is maybe more cost-effective and cheap. And of course, when it causes cure to a disease which was very expensive to treat, that would be something very good. But now, how is the government prepared to support research? Up to the moment, I think very few funds are actually released by the government to support research. If you plan a research that would cost 10 million for an med student, they will most likely not get that amount. They will get maybe 2 million. But now with the 2 million, how can you make a very nice research and come up with the findings that will help Tanzanians? That is a big issue. So maybe to start with, these are my few remarks.
Thank you very much, Dr. Eduardo, for that. And you've covered, as you said, you are very, you say. So, Dr. Skuzani Muya, Dr. Eduardo has mentioned about some of the public health issues. So, what do you think are the key public health aspects of GI disease, and especially malignant diseases? Karibu.
Hi. Okay. Oh, thank you. I think Dr. Kumba has pinpointed and highlighted most of the things that we face. Speaking of malignancy, as in I'm in the tertiary hospital, so I would think the most important part is the high emphasis on high suspicious index that this could be malignant, that need to be implicated in the very low health sector areas, as in dispensary, because that's where most of the patient goes. Like if a patient comes, most times the patient will go very early complaining of heartburn or constipation, parectal bleeding, but most of the healthy workers, maybe due to, depending on our referral system, like in the dispensary or district hospital, you don't find most of the specialists that side. So they start with the antibiotics, you know, the PPI and everything for sometimes up to 3 years. And if that is cancer, it means by the time they come to be referred to the high centers, that is like if it was stage 1, then that is like almost 3 to 4 with metastasis. So the main emphasis is the education to the health workers, because they're the ones who see the patient in the first place. And then improvement of the diagnostic procedures, like in the district or regional hospitals. The simple test that can be done there should be done on that side, so that when we're talking about tertiary prevention, that's treatment, at least we should be able to get this patient at a very early stages. I think that's, in summary, that's what I can say on malignancy.
Thank you very much, Dr. Muya, for that. Dr. Serafini Mroso, what disease prevention strategies should be prioritized in GI diseases?
Thank you, Chair. So regarding the strategies for disease prevention, GI disease prevention, we need to advocate that, because we need to prevent the disease primarily, but also early detection, so that you can prevent the morbidity and mortality. So there are so many strategies that we can deploy to prevent these GI diseases, ranging from the diet. We have seen some diet and the lifestyle is highly attributed to the GI diseases. We have seen diseases like metabolically associated dysfunctions. Diabetic liver disease is highly associated with metabolic syndrome. High fat diet, the Western life, but also some diseases like colorectal CA that is highly associated with taking red meat with low fiber diet. So we need to advocate the use of high fiber diet, for example, that can prevent diseases like diverticulosis, but not only prevention, but also treatment. But also we need to advocate on infection prevention. The strategies ranging from vaccinations. We have seen significant diseases that can be prevented by vaccine. We have a very strong vaccine for hepatitis B, for example. We have seen more than 70% of patients with liver cirrhosis in our setting is attributed to chronic hepatitis B. So vaccination is a very good strategy. But also we can treat all those who have already contracted the disease, and this ranges also for hepatitis C. We have very good drugs for hepatitis C, but also for other infections. The chairperson of Teagic and Dr. Ahmed took us through the gastric adenocarcinoma, in which it is highly attributed to H. pylori. It is class 1 carcinogen. So having the strategies for prevention of H. pylori, as was mentioned by our chairperson, that can help to prevent not only the tumors of the gastric adenocarcinoma, but also other H. pylori related GI infections ranging from gastritis, peptic ulcer, etc. But also we need to do early detection of some GI conditions, things like Barrett esophagus. So we have to make sure that all patients with GERD, symptoms of GERD, they are followed, because they are at risk of getting Barrett esophagus, and we know that when we identify it early, it's treatable. But also, Dr. Ahmed took us through the colorectal cancer. He mentioned that nowadays there's a trend. We see, it was not normal in the past, but nowadays the trend has changed. We see patients with colorectal cancer at young age. So probably we need to do our study and see what is, but majority they are attributed to familial adenomatous polyposis. So we need to do, when we encounter those patients with multiple polyps in the colon, we need to do, and with that family history, because it is autosomal dominant, so we need to do genetic screening to the family, because it has a 100% lifetime risk of developing colorectal cancer. So, and many times you can, it is advocated to do early screening, even at the age of 16 years, unlike the general population, of which it is advised to do screening colonoscope at probably the age from 45 and 50s. Yeah, so these are some of the strategies. When we play them together, we can prevent this GI condition. Without forgetting also the secondary and tertiary prevention. There are so many patients with already set geo condition, liver cirrhosis. We need to do an early screening, for example, to prevent hepatocellular carcinoma, like surveillance for HCC every 6 months, in which we should do alpha-fetoprotein plus an ultrasound, which is very good sensitivity. But also we need to screen for other complications like varices, in which you need to do appendoscopy yearly to prevent those complications. Thank you.
Thank you very much. So we have looked at the disease, the prevention, policy implication. Now the person has disease, we have to treat and manage. Dr. Tausi Mafta, can you take us on approaches for treatment and management of GI diseases?
Thank you for this opportunity. Yeah, for the management, of course, of these diseases, sure, cancer management is expensive, as everyone, of course, the president here has mentioned. Once the diagnosis is made, the journey of management is expensive, from surgery, chemotherapy, immunotherapy, investigations. All these are very costly. But of course, need to be done. And before you manage this patient, you need to know the extent of the disease. Knowing the extent, need several investigations to be done. I'll just advise broadly on the government to make sure the availability first of these diagnostic imaging services, at least each zonal or tertiary hospitals, so that when we do the staging early, we understand that cancer can be cured when diagnosed early, and of course staged at a very early stage. So when we talk on gastroenterology, of course, from the esophagus to the anus, there are a lot vast of therapeutic agents used, chemotherapy from the first lines to third lines, but speaking to the very advanced modalities of management, we have the immunotherapy and nuclear therapy, which of course some are not available yet in our country. For example, when you speak to gastroenteropancreatic cancers, you need lutetium therapies, which of course these somatostatin analogs, they are not available, and we just need to make them available, and of course involve also to have this private and public partnership to make these services available, and training of personnel to make the experts available locally, so that when you sit, because in management of cancer you need tumor board, you need a multidisciplinary team for the, of course, gastroenterologist, surgeon, nuclear physician, oncologist, radiologist, everyone to be on board. So these need to be trained in these advanced modalities of therapy, so that you know when at what point in time this tumor is refractory, this tumor environment is like this. So all those need to be understood, and you speak one language to know the behavior of the tumor, and you treat accordingly. You say now the advancement is personalized medicine. You can have the same tumor with a different biology. And it's not that you use one mode of therapy for the same tumor. you can have even 3 modalities for one tumor, depending on the behavior of the cells at each point in time. So this needs to be understood, and at least when the experts understand, they know at what point in time which modality to be taken, which investigation to be done. So the government, just to help this to be available, because sending patients outside Tanzania is very costly. These people are sick, they need relatives to escort them, they need accommodation where they go. The kind of president here spoke about, of course, lifestyle and diet. Our lifestyle diet is different from abroad. You are sick, you can't get the food you want. So being at home as a cancer patient is very favorable even for the prognosis. So management need to be done locally, and at least we understand our geographical behavior, and it is very easy because counseling also is a part of management in cancer patient. We need also, because it's a holistic approach, we need to take in all aspect in management of cancer. So understanding also these geographical and tribal issues locally is very easy than going outside Tanzania, which nobody can understand. Wewe ni umetoka Pemba, umetoka Songea, or something like that. At least the approach in taking care, which medication at least to counsel the patient is very easy to be done locally. Yeah, so they have touched the issue of research. It's a very important aspect because without research, you won't be sure of the direction of response, of therapy response to those kind of cancers you are dealing with, your community, what make maybe maybe gastric cancer or pancreatic cancer or hepatocellular carcinomas. Why are they common in certain area? So why are they, maybe you are giving this immunotherapy or chemotherapy is refractory? So those are issues which you need to bring on board to understand our issues locally, so that when we manage this patient, we know also direction, because we sometimes we just hit on the bush. You don't know the behavior exactly, who is not responding and why, so that we can also advise the private sectors and the government to make sure these things are successful. Yeah, thank you.
Thank you very much, Dr. Maftah. Now, this is an East African symposium, and we'll also look at regional issues. So, Dr. Anthony Okanit, can you enlighten us what you think are important regional frameworks that should be developed for better health care of GI disease in East Africa? Karibu.
Yes, thank you very much, moderator, and thank you for welcoming me to Tanzania. Hope next time I come and I can be able to interact in good Kiswahili. Yeah, so I'm going to, I've been given this opportunity. I'm going to actually concentrate on the gist of the first presentation. The first presentation actually concentrated more on the global burden of disease, where we are, and I'm going to talk about actually sub-Saharan Africa. And it was found out that actually that the most common problem we have here were mainly two. One was enteric infections, and the other one was chronic liver diseases. Chronic liver disease, and of course where we have cirrhosis there. And of course also not forgetting cancers of the GIT. Yeah, so let's go back to enteric infections. This is the 21st century, and we're talking about actually diarrhea. It was common, it's mainly common in the pediatrics, but we have it also in adults. Yeah, so we're wondering what is happening. What can we do what can we do more to prevent those diarrheal infections in this 21st century? So we had talked about regional frameworks. We actually have isolated frameworks, or rather isolated organizations or programs which are being run independently in different regions or rather in different countries. Yeah, and I may not name them, but there are actually very many. Some of them are concentrating actually more earlier on hand washing and hygiene, and then access to clean and drinking water. I don't know whether we still have them very active, but I think the best way to go would be actually to encourage regional collaboration between these frameworks, these different organizations. And actually, when you have those regional collaborations, we are able to appraise each of these different organizations. I can talk about the East African Community Health Regional Framework. We also, I think, have AMREF there and many others. And when we have those collaborations, I hope we'll be able to eliminate this or reduce these enteric infections. The other thing, if I move away from the enteric infections, is still the H. pylori. That has been talked about a lot. Yeah, so I'll refer back to where I practice from. Yeah, we have a lot of empiric treatment on H. pylori. Doctor have stomach pain, screen for H. pylori. Start on what? Empiric treatment if the antibody is positive. So we have unregulated use of these drugs, and then also we don't have standardized ways of screening for H. pylori. So if we are able to actually come up with algorithms that can guide us on how to treat, diagnose and treat H. pylori, this we could actually use to inform the rural non-physicians or the rural clinicians here, which are not actually specialists, which could actually help us to prevent these complications. One of the non-communicable diseases that we are at risk of, which is actually on the rise currently, is the GI cancers that has been talked about. So gastric malignancies on the rise. So if we are able to mitigate this H. pylori well, come up with our guidelines and inform others, I think that would be actually of good importance to digestive health. Secondly, to the non-communicable diseases, the leading cause previously in the recent past has actually been, when we concentrate on chronic liver diseases, alcohol and viral infections in the low and middle income countries. Those are the common causes. And we used to ascribe the other causes of chronic liver diseases to the Western world. That is diabetes and obesity. But of recent, in the current actually study of the global burden of disease, we realize that we're actually having it also on the rise here in our region, in the low and middle income countries. So how can we go about this? First of all, of course, we'd go to informing the society or the communities. What is the risk? As has been talked about by the chairman, what is the risk of alcohol? And what is its impact on disease and health, or our health? That is one. And of course also, we need to inform everyone, including the clinicians and the community on the preventable infections that give us chronic diseases, chronic liver disease, hepatitis B, hepatitis C, and the rest. I'm happy that we have actually we have a global guideline on management of hepatitis, but we have not adopted it so much locally here. I don't know or rather we have not actually found a way of rolling it out to the lower facilities, because still I get a lot of referrals, poorly managed patients who have hepatitis B. So this patient has been deceived that they are going to cure. For the last 5, 7 years, 10 years, ever since they diagnose the infection, by the time they come to you, they already have the complications, chronic liver disease. So how can we go about that? Informing the public, that can help us to prevent. So if we could also find a way of rolling out these guidelines that have been actually developed by the WHO, I think could be able to help us mitigate that. And of course, the other thing is on the diagnostics, really. Let me concentrate also on the diagnostics. in management of digestive diseases. Endoscopy actually plays a key role in diagnosing and management of liver diseases. But one of the recent studies that has been conducted actually here in sub-Saharan Africa shows that we have a very low uptake of endoscopy and utilization. That is both upper and lower. Yeah. Meaning that we're actually missing out a lot of these patients early. We are not they're coming to us when they already have the carcinomas. So if you're able to capture them early by enhancing the capacity of endoscopy and actually improving the endoscopy services. I'm happy today we talked about also integration of technology and AI into what? Into the diagnosis of GI disease. Yeah, so hopefully we should be able also to diagnose these patients early. Leave alone that we have very few specialists around the globe in GI, and if you come down here, I'm very sure even Tanzania, the president will tell us a handful, I'm very sure. If you go to Uganda, I can count all of them, I know all of them, all the GI specialists, the GI physicians. So, can we do task shifting in this case? Is it possible? And this has been done as a pilot in some of the countries in Africa. Yeah, task shifting. So what do I mean by this? So, we have a few specialists. Can you empower others, build capacity? Let's train those GI nurses you work with. Let's train the other clinicians who are involved in care of you in how to use these endoscopy services, how to diagnose, and how to also do the therapy. But of course, the key thing is diagnosis, even though they may not do the therapy. So this has been done in some places. I think there's a study from Malawi where that has been done. I think it was supported by the Belgians, and then those people were taken for, non-GI specialists were taken for training. They came for some period of time, came back later, and then they were followed subsequently. Their utility of the endoscopy and then their diagnosis, actually they were scored. And it was actually good results, as we had, not as we had anticipated. So, capacity building, training others, yeah? Yeah, that is what I would actually go on. And then the last thing, which has already been mentioned, is actually research in digestive health. Let's strengthen research. Yeah, I'm happy I'm a beneficiary of research. In the end, I did my MMed actually with self-sponsorship. But in the end, I got a sponsorship because of the research that I did. Someone was interested and said, let me facilitate you, continue with the research. So let's strengthen and support research. Research will not only inform policy, but will also be for advocacy and also attract funding to the digestive health care. So if you concentrate your research on digestive health, then you attract funding which can be able to give us the funds to buy the things we are talking about. Now when we're talking about integration of digital health, we switched off. I'm very sure I'm not the only one who switched off. But we're thinking of where shall we get that money? Well, it comes actually from the research. Yeah. Thank you. I think I'll first stop there for now.
Thank you very much. Please put together your hands for our panelists. They've done a wonderful job. I was taking notes. I just remembered my first year in medical school when I was learning new things. You have taught me a lot. I think, thank you very much. So, if you're excited like me, I want to invite you now to participate in this discussion. At the end, I'll give them 1 minute each to wrap up. But now, I would like to invite you all to join the discussion by contributing. You can contribute in any order. You can also ask questions, but I would like more. Let's engage in discussion. Secretary General, do you have someone taking notes, or is it being recorded? Okay, thank you. Karibuni, please. I want to see hands. Dr. Mohammed, I will ask you to say something on regional frameworks as well. We didn't have enough space on the panel, so be prepared. Please come in. Yes. Yes, thank you.
Ladies and gentlemen, habari. Yes, my name is Leo from the industry. And I have a question for our president of the GI Society. I think I'm with Dr. Anthony. Since the improvement of the awareness about H. pylori risks and even other digestive disease risks is very important. So as the GI Society, Dr. Kaba, do you have any plan to work on like a guideline for the management of H. pylori? Thank you.
Thank you. Thank you very much for breaking the ice. Someone to slide on it. Yes.
Hello. Good morning, everyone. I'm Dr. Ferdinand. I'm a fellow, surgical gastroenterology and hepatology. The first presenter, Dr. Komba, talked something about advocacy on trying to the society on trying to prevent these risk factors, which in the first place causes all these GI problems. Now, regarding the environmental risk factors, like the things that the population is consuming, like foods, drinks, like alcohol, and our efforts on trying to provide awareness to the population on how to prevent themselves from such risk factors. I can see there is a bit of a conflict of interest, especially with industries which contribute to the economy of our country, like these big companies, maybe Coca-Cola companies or companies for beers and stuff. Of those alcohol drinks, if the population consume them, they contribute much to the obesity, and that becomes a risk factor for these malignancies, especially the gastric CAs and esophageal CAs. So as the GI Society, the Teagic, the Teagic, how do we address this conflict of interest? If we go out there as doctors saying people should not smoke cigarettes, people should not drink beers and take alcohol, people should not take Coca-Cola, don't you think we are going to face a backlash? So that's a dilemma I want Dr. Komba to address. Another issue is we have seen a lot of societies, for example, in the modern world, and they're using the social media, the YouTube, the X, the Facebook, the Instagram, to raise awareness. And currently we have the famous Professor Janabi trying to raise awareness about the non-communicable disease like hypertension. So the GI Society in Tanzania, are we having such programs like using the social media? Are we having our own YouTube channel so that we can address these risk factors? And because now we're in the blink of social media, everybody is pushing their agenda through the social media, and it's becoming very powerful and very easy to raise awareness. So are we doing any efforts at GI Society in Tanzania? And the second speaker talked about things about management of especially people coming very late at the tertiary hospital, and she was emphasizing something about we should enable the hospitals down the referral system, maybe at the dispensary level, to have high index of suspicion and pick these lesions early so that we can have good outcomes. So recently we have endoscopic tests as an important test in picking these lesions, especially H. pylori, which have complications with upper GI bleeding and a risk of malignancy. But at the dispensary level, we don't have experts. And I know one of the qualifications, the minimum qualifications for someone to, for a clinician to do an endoscope should be a super specialist. And we have very few super specialists in Tanzania. So do you think we can run this marathon having a policy that only super specialists should are the ones to perform the endoscopy? Maybe the second speaker can speak about that. Maybe Dr. Komba also can chip in on that. What is the minimum qualification for a clinician to perform a recognizable endoscope? And then with respect to efforts in the prevention and treatment of GI condition, maybe the last speaker from Uganda, and maybe Dr. Tausi, is there any regional, any platform at regional level that we are collaborating maybe with Uganda, Kenya, maybe Rwanda, Burundi, South Sudan, that will address this GI, especially in the rise of hepatitis and liver diseases? Is there any regional efforts that are available? Because I think in the East Africa we are facing the same issues, and almost ethnically we are almost sharing some entities. And lastly, regarding the treatment of advanced malignancy at Ocean Road with molecular medicine, Dr. Tausi mentioned about having a tumor board with experts that are supposed to be very well trained. So currently, what is the situation? Are we having any liver tumor board, any tumor board available? And are we utilizing it? And what are the challenges? And maybe what should be done to make sophisticated treatment available in Tanzania? Thank you.
Thank you very much. You are very clever question for everyone on the panel. Okay, there's a hand there. When I see a lady, I cancel men. Then we'll come to your side. So.
Thank you. This is a question to the whole panel. With growing evidence linking mental health to gut health, especially amongst the youth, are hospitals and clinics treating chronic GI disorders with an integrated approach to psychological care? Are there any plans or practices of that form?
Thanks very much, our panelists, for the elaborative explanations. Mine yet is not a question, or rather a thinking, and maybe I want to share with others as well. Taking to the trust by Dr. Komba, who also was pointed by Anthony, research, whereby we could be able to generate data and information that will allow the practices, but also the trends of disease as well. Looking at the current situation that we decline in funding landscape globally across various disciplines, and that would have been posing another challenge, as if we can't have money for research, that means we won't be to generate more data, more relevant. So with that, what could be an approach to take? As we know, most of our governments across the developing world contribute little in terms of building capacity in research. So as the scientists and experts, maybe what would have been the way out from this particular situation? That's one. Two, linking it to what has been presented by my brother Lutfi earlier on the upcoming of the new technologies, especially the machine learning and artificial intelligence. As someone also put it earlier on, that we have a lot of data we are collecting of patients on daily basis. How could we utilize or make use of the information of patients collected on daily basis as baseline information that can be used to integrate into the new technologies that can be used to help inform trends of diseases by using the new technologies. Because if we can't have funds for research, what I know in the daily routine practices, we are generating a lot of data. So anyone in the room or the panelists can help with two things. How do we leverage the ongoing funding landscape going down, which hampers the doing research or clinical, generating clinical evidence data, and how we can use the new platforms available using the routine collected data, trying to inform the trends of disease, but also new interventions that can be generated from the data. Thanks.
I see a hand there.
Yes, good afternoon everyone. My name is Shaban. I'm a resident in clinical oncology. I think my question will be addressed to Dr. Komba and Dr. Muya. They have spoken a bit about capacity building in the lower cadres and the junior in the lower healthcare system. And I just want to ask if a thought has come or an effort has been made to strengthen in the training of these lower cadres in regard to non-communicable disease. I remember my exposure during undergraduate in the, for instance, cancer care. We just had a one-day visit to Ocean Road, and this is the practice, I think, till now. So I want to ask if there has been effort to review that and at least add an exposure to medical students so that they have a bit of understanding of these non-communicable diseases that has come to top now as compared to communicable disease. And the other is maybe to enhance the training in regard to non-communicable disease. Thank you.
Thank you very much. So I think we have good input from the floor, and every one of you have something to respond. So I wanted the president to be the last in the response, but due to other commitment, I would like him to start, and then we'll allow him to leave if one is done, and maybe he'll leave someone for us to take his place. Karibu. Una mwanachama mwingine wa society hapa?
Wapo wengi.
Wapo wengi, sawa.
Hata Serafini huyu hapo. Mroso.
Okay. No, anaanza president.
Thank you very much. I can see a number of questions have been directed to me. I would start from the representative of RIMA. I forgot your name, I'm sorry. But it was a very crucial question on the guideline issues. And we have said many times H. pylori is quite prevalent in our place. So do we really have a guideline? We have the national guidelines of management of diseases. And in Tanzania, it's actually one book with a lot of diseases, and many times it is being updated. And in that guideline, it has been stipulated very well how should we diagnose H. pylori, and the emphasis at the moment is on the use of non-invasive tests, and of course, preferably, we are using a stool antigen test, and we are actually advocating on the use of the urea breath test, and in very special situations, you can use the serum testing, which is, of course, we know it cannot inform you about the active infection. And the management, of course, yes, we have. But the major problem is, yes, we follow the guidelines, use the triple therapy, then quadruple therapy, and then you can have the rescue therapies. But we don't have the local sensitivity data on the bacteria itself, but at least recently one study was done to look at it, and we have seen some antibiotics which are really sensitive to the bacterium, but we really need more research on the sensitivity of the H. pylori infection to the antibiotics, and then we can actually formulate a localized guideline on the management on which medicines should be started as first line. So at least we have the guideline. The second one, this one is tricky. It involves the economy, it involves the health from one of the members regarding the conflict of interest of some of the risk factors on GI disorders, and the alcohol was specifically mentioned. And of course, I don't know if you mentioned also about cigarette smoking, which is another risk for the GI cancers. There's a really very big debate on what should we do. But always, knowing that there is an attached risk on the use of those products, then all these manufacturers have been by law informed that you have to state that if you take this, it is hazardous. So an individual is well informed about the risk of using that product. That is one way of educating you. And if you are aware that this thing is hazardous and you still take it, then we have to ask yourself, are you serious with your own life? And you have seen people suffering from complications of using that one. It's the same way as transmission of HIV. You know, unprotected sex, you can acquire HIV, and still people are getting HIV every day. Now the question is, what else can we do? So as the society, we'll keep on educating people on the risks of these products like alcohol and cigarettes, but at the end of the day, it is the individual to make a good decision how they can now further prevent the infections. The other question was on, this is quite crucial, as targets. How do we really take up the social media in actually educating the society on the GI issues? I should admit that maybe we have not done a lot in that aspect. At least we have a web page, interactive web page of targets, and maybe main things which have been posted there, it includes some of the maybe the meeting issues and things like that. But in terms of educating the society on issues regarding prevention or management or diagnosis of the GI issues, I think that area has to be strengthened. And I'm sure my colleagues are here and they are members of the society. We have to take this as a challenge. And in the future, at least we should show that the social media can be used very well to transmit information on GI disorders and their management. I would just go to one of the questions which was partially directed to me and partially to another speaker. in terms of who should do endoscopy in Tanzania. There are requirements that a super specialist should be doing endoscopy. I don't think if that requirement is from targets or is from the government as such. I think it is particularly related to what we call the insurance companies. And what is the interest on that? I know they want to see that someone is well qualified. At the moment, the insurance companies would recognize the fully trained gastroenterologist. And remember, an endoscopist is not a gastroenterologist. And an endoscopist would just do endoscopy and make a diagnosis based on that. But a gastroenterologist would actually do more than that in terms of management of GI diseases. I would support the concept of having short courses for training the endoscopists on properly doing the endoscopies. I remember one professor used to say, we have endoscopy pushers and we have endoscopists. He made a very strong point. It's not just a matter of pushing the scope into somebody's esophagus or stomach. You have to know how should I detect the lesions, how should I interpret the lesions, how should we properly conduct endoscopy. One of the key issues, how do we prevent infection transmission from the patient to yourself? And how should I manage, of course, the endoscopy suite, and how should I design it? There are a lot of issues. So to do that, we need short courses for training endoscopists and who should be certified. But now, do we have any in Tanzania? We don't. So maybe the major issue, we should now look forward to establishing short courses for that, and the persons or the doctors who will be trained will be limited to the diagnostics and refer patients for interventions to the gastroenterologists who are better trained. So in that case, in that way, we can pick up early cancers in the GI, and we can manage our patients better. So that is, I think, what I could answer on that aspect. In terms of research, how can we maximize what we have and conduct very, very good research so that we can innovate some things and we can help our patients better? Oh, I think in research, sometimes there is no shortcut. We need investment. We need investment. Go to America, there is a lot of money directed to research. Go to the companies, they have a lot of money directed to research regarding either the diagnostics or the therapeutics. But when we have the limited amount of funds, we cannot say we are going to sleep. And that's why at the moment you go to any university, MD students have to conduct research. This is a necessary component of their finishing that kind of training. So we should try to design a research that can actually utilize the little funds that we have. But at the same time, the one who asked the question mentioned, we have data which is collected on daily basis on our patients. You go to the ward, a lot of investigations are done, and patients are paying by themselves. So we have an archive of data in the records, and these days, thanks God, we have these record in soft copies. So in that case, it's very easy to use those records to design a research retrospectively and come up with some data. But the major issue, and most of us here are doctors and medical personnel, how quality that data is. Usually it's of very poor quality, and there are a lot of missing information. And when you want to conduct a retrospective study, you'll be having a lot of missing data. In that case, you cannot get that very good answer that you intend to get in your research. So let us improve. The clinicians should improve in terms of recording patients' information. And that would be key in the future in getting actually data that can be part of the research and answer a lot of questions. Yeah. The other question was now in terms of capacity building of the lower cadres Okay? Yeah, thanks God. If you look at the output of doctors in Tanzania right now, is quite high. Every year, not less than 1,000 MDs graduate, okay, at the level of MD. And at the same time, many universities now actually have established a lot of training programs, including the highly specialized training programs. I think I would say this time is not the Nyerere period. It's the time when people should actually force themselves to go back to school. Go and do your specialization. If you come to MUHAS, when we do the selection of postgraduates, we first look at who is coming from the over-the-country regions, from Rukwa, from Songea, from Twara. These are the people whom are given priority. Just come to school and increase your level of education. But at the same time, we have established these short course training programs. Last week, I was invited to close training on echocardiography, just echocardiography, because we know there is a lot of rheumatic heart disease in the country, so we want people to pick them from up the country. So these short course programs are also established to empower and actually to build capacity in terms of diagnosing these conditions. So when we see one condition is highly prevalent, then it's high time to establish the short courses programs. And MUHAS, as one of the universities in Tanzania, is actually keen on that by preparing these short courses. So I think at the moment, this is all what I have. If someone is still has not got the answer that they asked for, please, you can just remind me. Otherwise, I should allow the next speaker to respond to the questions.
Thank you very much, Mr. President, and feel free to be able to walk out when you think the time is there. But if you stay with us, we are more happy.
I will leave other questions to Dr. Mroso and Dr. Lutfi, please.
I know, and also, the other panelists, as they are responding, then we'll see if the answers are not captured. Yeah.
Okay.
So, okay.
That's it.
Okay. Dr. Mroso.
Thank you, Chairman. There was another question from doctor regarding seeing many patients with psychological problem presenting with GI component. Yes, there is a strong association between the psychological, including stress, depression, with GI condition. Much of which, when there is we call gut-brain axis, so when it is disrupted, together with other factors like changing microbiota and so many others, all together they can bring up the GI symptoms, like in IBS. So you only find you look for all the risk factors, for example, those with diarrhea, predominant constipation, predominant IBS. You cannot find one, but when you expose this patient to serotonin antagonist as one of antidepressant, you find out the patient is improving. So there is a strong relationship between psychological disorder, stress, with GI condition. Yeah.
Hi, hello. I'm going to respond on the Dr. Freddy. You were talking about, you were asking on high index of suspicion, okay? And I think on the part of who should do the endoscopy has been done, okay? So, you see, having high index of suspicion is the first step of sending the patient to the higher level. So it doesn't matter in where you are if you are able to access the investigation or not. Like we had a sort of training which was sponsored by the British Council and Bank of Africa. So what was the training was about is on the cancer is on the rise in the region. That was mainly on the East Africa. So what we did is the academician in the oncology part. So we had like a different setup of meeting, as in a conference, training to the attending physicians. These include medical officers and clinical officers. And the training was involving the different types of cancer. So there was like a presentation with different pictures from adult to pediatric. So if you are in the clinic, a patient comes with a complaint of a headache, because the first thing that comes to your mind as a clinician in the dispensary or health center, the first thing you think is a headache, this may be malaria, okay? But then this patient you've treated like consecutively a month, which type of malaria that doesn't respond in a month? This patient always come complaining of a headache. So now it's like, so if you see a patient with headache, you've treated with whatever that you think, maybe this is malaria or whatever that you think, and then still the symptoms persist, you have to think this could be something else. And this something else, can it be cancer? Then if you think on that line, whether it's a GI malignancy or brain tumor or gynecological malignancy, especially cervical cancer, this patient comes to you every day complaining of pelvic bleeding, contact bleeding, and you're prescribing antibiotic, and there's no response. Why don't you just do PV examination, speculum examination? Maybe you find something. And then if you're in a place that you don't have the facilities of diagnosis, especially if you've done the PV examination and you find there's a lesion, then this is a high time that you send this patient to the next level. If you're in the district hospital, then send the patient to the regional hospital, where there is a specialist. They will examine and then they do the biopsy if it's necessary. So this is what we are talking about, high index of suspicion. You in the lower level of referral should be able to see that because of these symptoms, then we should send this patient to the higher level. That's what we are talking about. And that's also answered Dr. Shaban's. The problem is, especially in the medical school. Actually, we see undergraduates coming to Ocean Road, one day, just a single day for them to be able to know cancer. That is impossible. So when they come, we just show them this is the LINAC machine, this is cobalt machine, this is where the patient gets chemotherapy, but it's not about what are the symptoms, what are the what are the diagnostic features, what are the management, you see? So I think there's like agreement with MOHAS that oncology should be part and parcel in the training of undergraduate. I think that is in the curriculum, the next curriculum that will come out. So that's all I can add up. Thank you.
Thank you very much, Dr. Okanit.
Yes, okay. So just actually answering the first person who asked question, actually from the first set of questions, yeah, I'm going to just reply two of the questions that were asked from the audience here. So the first one was on the endoscopy, the minimum number of endoscopies. So how many endoscopies should I do to be qualified as an endoscopist, or to be what? Recognized. Yeah, so I am not sure, but I don't think we have really a defined number of endoscopists one should do. So even in the Western world, they're actually using also, they're using their tools that they use to assess an endoscopist. So you as an endoscopy student, you have to go through an assessment, during your training. One of the tools is actually the direct observation of procedural skills, the DOPS. So it has different parameters which they assess. They are progressively as you do the course. So after that, you will graduate and get accredited and enroll to an association. I'm happy we have the Teagic here. Yes, so you enroll to Teagic, and now the question is, how do we proceed from there as an endoscopist? So when you qualify as an endoscopist, it is not done. So even as an MD, you enroll to an association. And I'm very sure after today, the MDs and the specialist doctors in the clinical field get 4 CPD points. So can we bring that to the endoscopy side, in the endoscopy in Teagic? Maybe that would be one of the ways in which you can assess. And I think it's what is being done in the Western world. So the question will be back to us, how do we go to that level of assessing our endoscopies? So back where I come from in Uganda, in the public setting, we actually have very few endoscopies. I can count the hospitals that have the endoscopy machines because I think they're costly for the government here. But the private setting now, we have many mushrooming centers with endoscopies. And then the quality of the endoscopy is coming from there. Sometimes you also wonder, you as a clinician, you've not done the endoscopy. So how do we go about to regulate that? So that is also a question for us to regurgitate today. And then the next question was on mental health. I'm just going to supplement. So mental health and digestive health. So as a clinician, look at your patient as a whole, holistically. I know we have a lot of diagnostics nowadays. We're in the sophisticated world. Now that there's even AI, I can diagnose you on phone. So when the patient comes to my clinic, I have all the tests. I can run them and get the diagnosis. But let's not forget our clinical skills. So usually I look at the patient as a whole. Sometimes the receptionist, sometimes when I see private patients, sometimes they wonder, why does the doctor take long with this patient? So interact with your patient, get the history. They come with stomach pain, doctor have stomach pain, and then you rush to the abdomen. But you may find that the patient actually has cardiac disease. So management of digestive health involves actually a multidisciplinary approach. So you need the MDTs there. So you have the nutritionist should be on board, the gastroenterologist should be on board, and many others, and other specialists which are needed. Thank you.
Thank you very much. Dr. Mohammed, would you like to chip in because you have various hats? I know we are coming. You have several hats, and we want you to talk about the regional frameworks in terms of associations like Jamii Bora, Teagic, and where you are working, how we can read. So maybe, but if you have a longer presentation.
No.
Yeah, okay.
Yes.
Okay.
Maybe you could repeat the question so that.
Yeah, I want you to talk about how can we employ or adapt the regional frameworks to improve issues of GI.
Yes. Thank you, moderator. Actually, I wanted to speak on the first, what are the gaps we have for the regional frameworks. As you know, there's a very limited policy prioritization for the GI disease, and we know most of the country, they have the non-communicable strategies, and we would like, if possible, we could have incorporate GI issues on there. So most of the country, especially in our region, need to do that. We also don't have enough sufficient data for this. And the other thing which is common is inadequate workforce and poor access to the diagnostic tool. As we can see that right now, there's a lot of innovations, which is good, but still we don't have enough tools. Then the lack of standardization of treatment protocols and weak preventive services, because we know that if we can early detect and diagnose this disease, we can be able to prevent further progression. So those are some of the gaps. Now, what needs to be done? So first, we need to enhance our policy and strategy development so that we can integrate the GI into regional NCD plan. So we can try, like we are happy that Jamii Bora partner with other organizations to ensure that this conference is happening. So if we can manage to integrate and having all these partners together, working with the government and non-government organizations to ensure that we advocate for GI to be incorporated into those framework. And we can just start by having the regional policies, and then country can adapt based on their demand. The other thing is now we have to strengthen in the workforce development to ensure that countries can be able to train and make sure that we have enough experts on that issues. And then the issue of research need not to be re-emphasized. We need to ensure that we do the research and get the solution, especially sometimes we can do the operational research, because those ones, they can answer a lot of questions on what can be done in our regions. And then increase the access to diagnostic and treatment, and to ensure that we have preventive services and public health advocacy on this. And then now the regional collaboration and integration with various actors. We know that apart from these societies and apart from our other partners, we can also use organizations like African CDC, which is one of the Africa regional organizations, which can also be part of this. And then we have several other regional entities which can also. Thank you.
Thank you very much. So, Dr. Mafta, you have the last word.
Thank you. I just want to respond on the doctor's question there. If there's any regional or any platform at the regional level in management of GI conditions. Of course, yes. We have, I can take example, we have been together with Kenyans, of course, in management of oncological conditions. Of course, there's a society there. Of course, there's, we say, KESHO, that's the abbreviation of the society in Kenya, and of course, Tanzania Oncology Society, and of course, the East Africa Oncology. Of course, and now the president is Tanzanian, so at least in the region we have tried to work like that. And management, of course, of all conditions, including the GI. But of course, our friends in the region, of course, Rwanda, because we have MUHAS, the training which we do for the GI at MUHAS, and of course oncology, Ocean Road. These we receive international students, and when they go back home, we keep them on the loop. So we have been together, and now as we have that close communication of what they are doing, of course, with their patients and us. So at least in the region. But American Cancer Society had tried to unite Sub-Saharan Africa to harmonize the NCCN guideline to suit the Sub-Saharan Africa, and this had included surgeons, gastroenterologists, all the specialties, radiology, pathology, nuclear physicians, oncology. Yeah, so we have went through the guideline, and in each category, from prevention, diagnosis, management, and follow-up. So all the guideline of the NCCN to harmonize to suit the Sub-Saharan Africa. So that at least had make us together in the loop, so that we take this together. But in the tumor board issue, yes, I agree that a tumor board is there, for example, the one which was existing, but it was lacking some of the strength, especially, you know, when you talk about cancer, you need expert. There's no other way. You need expert, so that when it comes to the decision making, really you make a strong decision that for the way how to treat that patient. But it has not been that strong. We agree, but recently we have sat down again, and this, as I'm speaking, it just happened this week. Another decision has been made that instead of doing that tumor board, which is just the general tumor board of everyone there, whether you are Max Fash surgeon, whether you are breast surgeon and oncologist and gyne, whatever. So now we will do organ-specific tumor board. So that will make it easy for the specialist on the same specialty to decide on these patients. Because what has been done, maybe I can just say with my experience that I know maybe Dr. Komba here, Mwanga, Dr. Mwanga, Kitembo, Pazi, yeah, Sangeti, those Mchele. So those who are surgical gastroenterology and physician gastroenterology, so you just like, you work together like that. So we have been like that working, but of course, this decision which has been made, as I say recently, to go organ specific will make it very suitable, and of course to strengthen the management of these conditions, which of course for our patients. Yeah. Yes. Thank you.
Thank you very much, Dr. Mafta. So in this panel discussion, we attempted to take a journey to inform, to discuss among ourselves the policy implications of gastroenterology, but also the public health considerations in terms of prevention, treatment of gastroenterology, as well as discussing what regional framework should be developed. And I think from what we have heard, we have done, my panelists have done a good job, and you, the members of the audience, have contributed a lot, and I hope the organizers will be able to summarize and come with a good recommendation. So put up our hands again for our panelists, and thank you very much. Asante. Okay. So thank you, and we can step down.